we may.
A few months younger than
Finish
Well, welcome everybody. We're going to wait another minute or so, and then we'll start our seminar. Got quiet. Okay, thank you for everyone that's joining us online, and we have a hybrid event here, so really fantastic to have some people in person. We're really pleased and lucky to be able to have Dr. Sujoy Kar visiting us from India, and he's here for another purpose, and Chris Dane at Monash University put us in touch. Sujoy and I talked about just the incredible AI things that they're implementing in India. So really looking forward to learning that. He's the Chief Medical Information Officer and the Vice President of Apollo Hospitals. Thank you. This is why I asked Eileen to put an acknowledgement of country slide in so I wouldn't forget, and yet I still forgot. So let me just start by acknowledging the traditional owners of the land that we're on and paying our respects to elders past and present. Okay, so Sujoy was previously the medical director of Apollo Glen Eagles Hospitals in Kolkata, and he's a clinical microbiologist by background, with subsequent post-graduation from Indian Statistical Institute and MIT Sloan School of Management. He's an adjunct faculty for healthcare analytics and management in Calcutta at IIT and at the IIT Kharagpur and Apollo University. So many different roles from academic, research, and operational. Really looking forward to your talk. And feel free to come up to here and excellent.
Good morning. I came here about 6 days ago, and I've started feeling that Melbourne looks like my second home, upstage in Boston, where I have gone about and studied. But the gentleman who got me here, Professor Chris Dane from Monash University, he promised me that this week we will be having all the 4 seasons. I haven't seen the rain yet. So on the accuracy, on the accuracy perspective, we are 75% there, which I do not know from our clinical parlay whether it is good enough to get started by making your prediction algorithms at 75% and then saying, how do you go about and implementing them in your clinical workflows? But truly grateful, Professor Wendy, for inviting me here. When I was coming down, possibly for the first time, I saw that there wasn't my name in one of those visual displays down there. It says I'm coming up here to give a talk. So in the next 35-40 minutes, I would cover what we have been doing at Apollo Hospitals, but also leave behind some fundamental questions that we face today in the implementation, or in many ways, what we call as design, development, validation, and deployment of clinical AI solutions across clinical spectrum as we get more and more data collected electronically from our medical records or our imaging systems and packs, but then also getting into what I call as high velocity, high volume, and high variable data, where you have anything from a video to a genomic data to a histopathology slides to whatnot that we can possibly go about, including what you get through your wearables or machines that are spitting data from a bedside of a patient. How do we analyze all of these? How do we interpret all of these? And how do we make conscious clinical decisions that are related to the outcome and impact of a particular patient? That is what we all are striving here today. There are, hundreds and thousands of people outside this room who are also doing the same work. And we are all on a mission to actually see how we navigate clinical AI in its rightful way. I would start by giving you a little brief about the organization I represent. This is our beloved chairman. He is 92, and he found Apollo Hospitals when he was 50. That's about exactly 42 years back, 150 bedded hospitals in a place called Chennai. And those of you who follow cricket, you know where Chennai is, because the fact that, there have been some great test matches and other cricket matches between India and Australia there. But I'm not too sure about what is going to happen in a few hours from now in Perth, right, where we play our first test. I hope that the match goes beyond the second day. So Chenin came out with, he was a busy practicing cardiologist at Mass General Hospital. And then he came back to India in somewhere in mid-70s and started his practice and said, I'm in many ways constrained by the resources that are around me because there's very little that I can do for my patients. And that's where the whole birth of private hospital system in India took place at that point of time, where he began to build organization one after the other in providing adequate resources for the doctors, and in many ways the doctors to come back from people who are practicing at NHS or in US, having appropriately trained to come back to India and start their practice. So he had transformed clinical medicine in India in many ways with a very, subtle vision or mission to maintain excellence in education, research, and healthcare for the benefit of humanity. And that's what we're talking about. I met him about a couple of weeks back, and he was talking about what are you doing for the last mile? So in digital health, we have that power to actually take it to the last mile and to see what we can possibly do. It's been more than 40 years legacy of transforming healthcare. We now have about 73 hospitals, close to about 11,000 beds, and as many 1,570 diagnostic centers. We are one of the India's largest, if not the largest, telemedicine network, which was actually inaugurated in the year 2000 by Bill Clinton when he was visiting India. And, so this was in year 2000, and we never had a national document for implementation of telehealth until COVID came up, and we got that standards done only in March 2020. So you can understand that we have been working in many ways where there are a little dearth of standards, particularly in AI, telemedicine, and digital health at the moment across the country, but in general also across the world. We would have touched about close to 200 million lives, 17 million in terms of teleconsults. Now, you would get to see all of these numbers when somebody from India or China comes and gives you a talk because of the number of people we have or the population that we have. And our digital front arm, and I'll talk about a couple of slides in that as well, have now been able to do around close to 25 million registration with about close to 1 million daily active users. And they also provide about close to 40,000, pharmacy orders on a daily basis. Now, the whole purpose of giving you the extent of the organization was to have a single system at the backend to actually bring in all the transactional data from patients or the EMR to do full purpose. And these purposes are not different from any other organization across, the hospital across the street would have very similar purpose as well, to actually do the empower your patients, support your clinicians, optimize operations, particularly looking at the throughput and also enhancing patient safety. But in general, to also provide insights to what is happening around the community and to see what are the disease patterns or changing disease patterns, what we call as particularly in infectious disease, emerging and re-emerging trends, which are very, very important to actually identify and navigate through over a period of time. But I would like to take you to another challenge from a digital health perspective, where we are looking at how health equity is a global challenge. And it's digital health, that whether we do it at Apollo Hospital, whether we do it at Australia or whether we do it across any other country, is evolving as a global challenge. And why we want to bring this up in the discussion up front is to say, we have certain steep objectives to follow from a digital health perspective, particularly from an absence to unfair, avoidable, or remedial differences in access to care. But then also look at it from a perspective of healthcare organizations, how they go about in looking at it. Because sometimes it's difficult for healthcare organizations to also look at how do they prioritize human rights and social justice, and how do also they look at it from an economic development of the population that they serve. And then the whole purpose of lack of data, and whether it is anywhere in the world, we are now seeing, of course, people migrating to digital health and then collecting their data in the EMR and all of that. But we all know at some point of time we use the paper and the pen to actually document what is happening around the patient. And then how do we then go about in enabling health data from public and private organizations to overcome the kind of bias that comes in? And then when you are talking about the digital solutions, when you are talking about AI and all of these, internet becomes a very, very important perspective. So in one of the Broadband Commission report, where we were one of the people who contributed, we identified that there are 4 billion people across the world at this point of time who do not have smartphones and internet. Now, if you're building digital solutions, are you then creating another layer of bias on top of it? Because you do not have people with adequately, from a lack of internet and devices, lack of digital literacy, trust, privacy, and of course, the question of diversity and inclusiveness. Therefore, the question that always comes out in the health outcomes, and particularly the AI affecting the healthcare, are we then identifying algorithmic bias in an appropriate way? Are we defining fairness in a proper way? Are we then collaborating with each other to find out accountability in that way? Now, to build all of these, we have at Apollo Hospitals defined what we call as the building blocks. And I'll quickly introduce the 9 steps that we take to actually go about in using this whole path to say, how do we go about in building AI solutions, particularly starting with ideation, design, engineering, development, validation, integration, and enhancing the usability for everyday clinicians in that perspective. So we call it as a basic 9 yards, and I'll just go back to show you what these 9 conceptual highlights are. Now, this is something that from our own internal research, we have been able to design and develop and get it there. So the first step is that of an ideation, where understanding the clinical area where a potential AI ML model will benefit the physician, patient, hospital, and the digital platform. So what are the kind of people, what are the support or resources that you require to go into an appropriate ideation phase? You require the clinical consultants to come in. So if you're building something where you are looking at a response or an outcome of a baby at the neonatal unit, you would then look at bringing a neonatologist to your ideation phase and say, Doc, what is that we need to look at the data from? Also, the other thing that you need to do at this point of time is to look at what is the existing literature, what are the clinical pathways that you have built. Now, there are 2 distinct things that we have been seeing now, particularly in the generation of large language models, is that one is where you use technologies like retrieval augmented generations and RAG as technology. You need to actually look at what is the authoritative source coming from. And your authoritative source in most cases would coming from the the publications or the guidelines that are coming from authoritative sources, but don't discount on your own data where you have 10 to 12% variation for the work that you do at your unit from that perspective. And therefore, bringing the data and bringing your consultants and your clinical pathway is very, very important in the ideation phase to actually begin with. What happens is that in one of the steps when you go about in doing the adoption of this technology, they would always be your partner. In many cases, we have seen that when we build algorithms behind the desk by the data scientist, it normally doesn't work because it does have a disconnect between what the clinician is saying and what the data scientist is saying. And therefore, then once you've done through the phase of ideation, go into the data management. And I don't need to tell this, a lot of people must be practicing all of these here, but I also look at it from an EMR, PHR to see, what are your EATL strategies. And the reason why I put in the anonymization protocol is that very important aspect to actually look at patients' privacy, confidentiality, and security from a perspective in that. You can bring in IT teams, and one of the things that I talk here about as partners is an organization that you would bring in, like, somebody who would help you out with, different phases of this data engineering work. Once you've done that, you move to analysis and modeling, where you use statistical analysis and AI modeling to use appropriate algorithm to augment the clinical need, get these answers from your data, and then, of course, the inferences. And then again, go back to the in-house teams to actually say, this is what I have found, or this is what we found during the crunching of this data. How is it meaningful? At some point, you need to actually go and look at the ethics. Now, I have seen this from very, very good and reputed institutions across the world because I partner with them, and I've asked them, do you then go to your ethics committee to look at the retrospective data for which you are analyzing? And they said, no, we've taken a blank. My question to them, and my question to many of these people who actually evade ethics committees into this, is that you are going to now find out something, some delta by looking at the data. You will make some suggestions or certain suggestions or certain inferences which will modify the way you are delivering your care. And that data needs to be ethically evaluated and then placed in ways that it goes and then gets into work. So ethics and to an extent regulatory perspectives are very important. So engage with your clinical trials teams, your legal teams to understand what the data is telling you, particularly if you're going to make prospective models from retrospective data. External validations are also very, very important in this perspective. Many of the work that we have seen over the past years, of course, is changing now, is that a lot of these data scientists with particular data from one institution would make wonderful AI or ML algorithm, and they will stick to that. But the age is how you go about across the borders, across continents, going to different geographical and ethnic population, and then go about and validating your models. And I'm sure your models will not be the same again. The accuracy performance of your models will be different in different ethnic populations. So therefore, the validation requires a different approach that I could be discussing in a while. Then, of course, on the sixth step is where most of the academics would like to do it in terms of presentation and publication. But that's where the other work starts in, where you convert the algorithm into an API and begin to integrate that into your EMR for prospective use. This is where you also need to go about in building your consortium and network across the world for validation, calibration, and co-creation mode. Look at the regulatory, and one of the things that we have very recently done is actually to do ISO 13485. Of course, we have been doing that ISO for about the last 4 years now, but very recently, medical device single audit program, which actually includes US FDA, Australian TGA, Health Canada, Japan, PMDP, and then, of course, the Brazil ANVISA. And then if you look at, if there is a viability of this, to actually look at it from a commercial platform as well. So this is a gist of what it does. Starts with the clinical coordination committee, looks into the data, transform and harmonize, go to the ethics committee, look at the statistical perspective of your data, see what is the quality of your data at that point of time, start machine learning from a very basic to go up the ladder, including deep learning, reinforcement, recommendation systems, and of course now more and more on the sides of Element. But this is where a lot of institutions would stop. This is where the journey actually begins for an algorithm where they are then converted into an API, put into a container, taken in across the world through a confidential computing layer, certified, and then go about in integrating them into digital health or in the different EMRs. So at the moment, we have about close to 35 different projects that are ongoing at Apollo hospitals with various partners. And what we have gone about in doing is to divide this whole thing into 6 different parts. The first one, and I'll show you how it works, is what we call as the clinical intelligent engine or the clinical decision support system as workstream 1, but this workstream 2 for the data. Okay, I never told you the amount of data that we have at Apollo. I did say that we have seen about 200 million people, but we have now about close to 45 million people's data for the multiple transactions that they have done over a period of time. So what it does is actually looks at this curated data set from the perspective of anything that you want to look at, say cross-sectionally, whether it is a lab value, whether it is a imaging, or image and their reports, or whether it is a genomic data or the medication that the patient gets, with an associated factor of the outcome for each one of these transactions, and then map it across a time series to actually go about in doing what we call as the disease progression models, which we now have for cardiovascular disease, the diabetes pathway, or the liver fibrosis, acute exacerbation of COPD. And then, of course, for very lately for chronic kidney disease, where we are now looking at a velocity of deterioration once a patient has certain factors, how quickly they're moving into end-stage renal disease. We've been also working on image and signals thanks to our collaboration with Google here, where we have been working on chest X-ray anomaly and tuberculosis. And then, of course, some work that we have been doing on acute care, which we can possibly think about in terms of antibiotic stewardship, in terms of how you go about in providing a patient anesthesia, adult early warning signs, and of course, we now are moving to pediatric early warning signs, but of course, at some point, also looking at the neonatal early warning signs as well. And by February, we'll be releasing some of our algorithms on hypertension pathway, a liver fibrosis pathway that we have been working with Siemens, where we are now embedding our algorithm to the Siemens ultrasound machine to detect people with fatty liver. What are their probability of having liver fibrosis, cirrhosis, hepatocellular carcinoma in that pathway. And yesterday I was at Victoria Heart, and I was meeting the director, Professor Derek. And of course, this is not the first time, but then I heard him saying, Sujoy, what exactly are you doing with this patient with, NFLD and then, of course, MFLD now? And then how the perspective of liver fibrosis is actually bringing in, concepts around cardiovascular disease. How do you bring them together? And that's, again, something, we are possibly going to work together to actually identify the follow-up of these liver fibrosis patients to see, what are that we can go about in doing it from a cardiovascular perspective. But some work that we have been doing on the ECG heart failure pathway, which we presented to American Heart Association last year, where we have taken the 12-lead ECG, converted into an XY format so that we can actually go about it, plotting it in a much more detailed way in your Excel file. And then take that with the patient data, merge it together, and see if you could go about in predicting heart failure 3 years before. So we are at the final stages of this work, mammogram work that we have been doing with MIT algorithm, we call it Mirai. And the purpose of Mirai is to detect if somebody has, breast cancer in next 5 years, but look at it from an annual projection to see breast cancer in 360 days or then 2 years or 3 years and so on. So some work that we have been doing on stroke AI, particularly aided by work that we are doing on the ECG, and then some on the work that we have been doing on the NLP stacks, early warning signs, and not just look at the cardiovascular deterioration, but also other ones. Sepsis with blood counts, and I'm going to have a slide later on to actually tell you, what we are doing with the University of Cambridge, where we're identifying about close to, okay, here's a question. You see the blood CBC report from a patient in a, complete blood count. In a complete blood count, you would see about what, 20 to 25 different parameters, RBC count, WBC count, hemoglobin, platelet count, and then different measures that come in. From machines, we are now able to derive close to 3,000 signals from your Siemens machines or from the Sysmex machines of your hematology analyzer. And we are now using this and working with University of Cambridge to identify early signs of sepsis, looking at those parameters and to see if there is something that we could do about in early prediction. We are one of the Google's MedGemini validation partners. So when you see that some mistakes comes out in MedGemini, blame us for that. because we were the ones who actually doing it at the back end for Google to actually see how they go about doing that. And we're coming with our first genomic model by end of next year. By end of by middle of next year to go in that way. I see some questions coming in.
We'll save those for the end.
Right, yeah. But at the core of anything that we do is to actually put it in that perspective of responsible clinical AI through what I call as a pipeline of trust that reaches from the algorithm, and the final beneficiary of the trust is the patient, but it runs through clinicians. I've seen often people talk about, there was a report 2 days back which came out in MIT Technology Review. It said, algorithms alone are doing better than algorithms plus clinicians. First, they said algorithms plus clinicians were doing better than clinicians. Now they're saying algorithms. And I will take that with a pinch of salt, because human interpretation in clinical medicine at this point of time is still very, very relevant and important. And it is all about how humans use this technology for, in the context of clinical care, and then look at it. Because you cannot negate in any kind of an AI flow to look at certain things like consents, consideration, privacy, or confidentiality. So, this old saying about if the AI is then going about and giving certain suggestions about the care, it is like using a technology where you need to inform the patient. And the consent is always going to be the informed consent. I know that there are a lot of debate about the word. People don't like me saying this, but I always say any technology that you use at the bedside for the patient, nothing about you without me. So it's very imperative that we actually look at it in that way. To do this at Apollo, I know we have several of these frameworks, and Professor Wendy, you may be, looking at many of these frameworks, both from an Australian perspective, but also from a global perspective in order to design and develop. But we came out with a paper where we have an in-house way of looking at how we bring in the ethical element from the AI development and deployment, and then from the clinical side, and merge them together to build a framework called EASE, which has safety, non-maleficence, accountability, efficacy, accuracy, integrity, fairness, inclusivity at one side, but also from an adoption perspective to say, what is the real world evidence that is there for, the professor at unitology to actually use this intervention at that point of time or that point of care. And then, of course, look at the clinical need or suitability from the perspective. Why are you building this algorithm? Why do you want to bring in AI in your system? What is the clinical need? Understand that. Address the bias, and I'll talk about the deployment bias. We talk a lot about design and development and the data bias, but we do not talk about the deployment bias as to what you see on the downstream of an AI algorithm's adoption. And finally, I want to at some point at the end of this talk, I will actually highlight on the point that we are beginning and getting into an era in clinical medicine where there are going to be conflicts between human and machine. And how do you then go about in solving those crises, particularly at 3 a.m. in the morning, when it is left out to either a junior doctor or a junior nurse to decide for a critical patient? That's going to be very, very interesting. And then the whole factor of explainability, where you are looking at not only explainability that comes out of the model, but then how do you go about and telling it to your patients in a rightful way. Now, in all of these constructs, this is a research which got published a couple of days back, and there is a Microsoft blog, and they made a lot of noise about this in the last Microsoft Ignite event that was there. So what it does is that at Apollo or at any one of our partners at this point of time, what we do is actually then go about in providing algorithm where the data side does not see the algorithm and the algorithm side doesn't see the data. The first and foremost is data remains within a particular organization where it is meant to be. It is pre-processed in a way where it is anonymized, and one of the anonymization protocol that we have built at Apollo is now better than one that Microsoft has, or Google has, or Johnson Labs has, to actually see, how we anonymize both from a textual and also tabular data, but also from images and genomic data as well, to actually, do the pre-processing and then go about. So we moved on from a pre-processing perspective. We are now moving on to actually doing a lot of OMOP-related CDM work. So the reason why we are doing this is to actually bring in standardization on the data, and then more about go into model training and fine-tuning. And we have got now the results. The results are excellently well, or almost similar to having a GPU at your, at your labs. In the terms of electronic medical record. But we don't know yet about the data with images. We don't know yet about videos. We don't know yet about the system, how it works on genomic data. So we're getting there. It's a constant research that we're doing this. And then, I want to shift a little bit at this point of time to taking it from a perspective of privacy and others to the entire risk management flow for this. And anyone who builds AI at this point of time or deploys AI has to take a risk-based approach. Look at how you build your own failure mode effect analysis or hazard vulnerability analysis in your both processes and sub-processes in your systems. And look at, one of the ways that you can actually do it is by using ISO 14791 templates for residual risk formats that we develop here. And to see, what is your residual risk of having a particular solution being deployed in a particular area. And then how do you go about in having risk control measures for those key risk events to lower your overall risk, and then go about in using it for your production, and then seeing how that are going in and doing it. Mind you, a lot of people do this in terms of design and development, but a lot of people don't do it in terms of deployment, or what we call as the post-deployment in this perspective. Now, to move from risk to having conversations with clinicians, we made good algorithms. We went with a good dashboards and others to our clinicians, and they shot us in the very first and said, nothing's working. We made a very good dashboard with our early warning signs, possibly not there in this presentation, but if I get time, I'll just pull that out and show you. And nurses say, good, well done, well done. But it is so complex that it is not making any sense to us. What do you do about it doing this? So the perception of the healthcare workers, or physicians or clinicians for that matter, is varying on the impact of AI, because in many ways we have not designed either the development or the way we have designed the APIs or the SDK versions of this in a way that it would actually improve patient outcomes, or others may be very apprehensive about this accuracy. Begin the conversation, have this conversation within your organization, bring in the right key stakeholders, but don't discount on the most new employee in the floor and see how she's using it when she's using it on the patients. It's very important to do that. I'm also going to talk a little bit about the skill gaps that we see. I'm going to now give some examples of how we have adopted in the hospital. I gave you the example of what we do in symptom checker and CDSS at the hospital. what essentially that does is that given the symptoms of the patient, it discover causes to symptoms. It looks at labs and imaging tests, drug interactions and safety advice, discover specialty and doctors, and then what we call as a health journey, which looks at the complete consumer records to provide actionable next steps. And for the clinicians, it looks at an assisted doctor consult. So it does a kind of a review of a patient, just like a junior doctor would do before a consultant would actually go about and seeing this patient. So builds on a case info, gets a case summarization, and does a complete case analysis to say what they're. Now, when we started this, our accuracy was only about 65%. We're not doing good. And a lot of doctors said, we're not going to use that. And then we continuously went about in doing a lot. So it took us about 3 years to get where we are. We now have an accuracy somewhere near about 80 to 85%. Some disciplines do better. Some disciplines like mental health, dermatology, and others are not doing better. So we are working constantly at those ends to actually improve them, to actually take it there in that way. So what it does, so it helps the patients on an on-demand symptom checker, which would then take all of these parameters to give you an assessment report, give you the top 3 diagnoses, the doctors whom you can consult, and then, of course, gives you a symptom history and a triage alert when and where you would go and see this doctor at what point of time. And then to come back to use on top of that layer disease progression models, both within the hospital system and then also outside hospital systems in something like what we call as a health camp, where you go and select and give all the necessary inputs to this patient, and they would then provide you. These are all the inputs that you are seeing from this patient perspective, and they will give you then the model will then provide you with a risk score at the end of it, with what are the lab investigation, diagnostic imaging, referrals, advice, repeat visit, treatment protocol that you would need to do. Then you go and put this with the patient and follow them up to say all of these are done, and then you see, what are the secondary risks that are coming out of these patients at this time. Well, we have used this for about close to 500,000 patients already. So if you're looking at it from a perspective of how we have rolled out our clinical AI, last night I looked at my team and said, what is the count? And they said we have used now for 2.5 million people already. And this one, we have just done 500,000 recently to go about from that perspective. Anyways, moving from what we see in disease progression models to effective, looking at the effectiveness of generative AI. How many of you in the room have actually looked at generative AI in your practice at this point of time? How many of you use Copilot on a regular basis, even if it is not for clinical, for other things? So here you are. Now the question is, how many of you are aware that there is an agentic AI that is going to be released by OpenAI in January called Operator? This is a news that came just 3 days back, 3 or 4 days back. We are entering into a world where now conversational bots or the agents are now going to become part of our life, part of our practice. How do we do this for healthcare is going to be a challenge. And challenge in many ways, particularly looking at their autonomy, particularly looking at their accuracy, particularly looking at what is the kind of data that they are fetching at the back end to make those, predictions. And, in the name of precision medicine, what that is precise and what that is something meaningful for the patient at that level of care. So here's an example of one of the agents that we have built. Now, what she does is that she looks at the outpatient diet consult, And she was doing it pretty well for the outpatient consults when we were doing this, and I can play that video as well. But then we fed her with the data that is required for drug-food interactions and food-food interactions and others, particularly in a critical care setting. And once you upload an assessment, even if it is handwritten assessment, they will then read through and prepare a summary. Take a listen.
Fruit with antihypertensive drugs like cilnidipine and telmisartan to prevent adverse interactions. Low potassium diet is crucial for CKD patients to avoid complications from telmisartan. Consistent carbohydrate intake is essential to prevent hypoglycemia, particularly with insulin use. Limit alcohol-based food or medication to avoid interactions with aspirin, clopidogrel, and diabetes medications. Avoid herbal supplements such as garlic and ginseng, which may increase bleeding risk with antiplatelet therapy. Ensure adequate vitamin B12 intake due to metformin use and incorporate calcium and magnesium to prevent deficiencies from long-term pantoprazole use. The report emphasizes the need for continuous coordination between healthcare providers to adjust dietary and medication plans accordingly.
Can you describe what are the complications of this diet for this patient?
The diet plan's complications include managing low potassium for CKD, avoiding grapefruit due to drug interactions, ensuring consistent carbs to prevent hypoglycemia, limiting alcohol-based foods, and avoiding herbal supplements that increase bleeding risk. These challenges require precise coordination to prevent nutrient deficiencies and drug interaction risks.
Okay, this is a nine-minute conversation. I will not go into the entire thing in that. But what I wanted to reflect is this, that these are the agentic AI that are going to now come where you are able to converse with these people, with these bots more and more in your daily systems, and then go about in identifying what problems you have. And one of the questions I was asked in St. Vincent's Hospital a couple of days back, there was a person from clinical informatics, and she said, Sujoy, it's all good that AI gives us certain inputs in all of that. Do you go about in documenting that in the medical record? Because if there is a risk or some problems arise out of it, I would say I didn't take the decision, AI did. Of course, in a digital health systems, you should have systems of traceability where this particular opinion is coming from. And in particularly if you have a hand record at this point of time, and if you're using a hybrid systems like this, you would then need to put it in account that this was given by the bot at this particular time. The bots or the electronic system will always have their traceability, but that traceability also has to be there in the medical records in one or the other way. Now, does that increase our documentation load? Yes, it does. Particularly if you're looking at something like an early warning sign, which has to be monitored every 2 hours by a nurse who is looking after 10 patients in a ward, that's cumbersome. And therefore, the whole idea of looking at it from a digital transformation, also from the hospital, is very important. Now, going back to the agentic AI, and there are some very serious questions that have been asked. If you follow this organization called ARPA-H in US, who are now looking at how the AI or digital health is now going to get in shape, they're asking questions about the agentic AI's autonomy. They're asking about how you are doing with multi-agent collaborations or bringing in multimodal data, particularly in an agentic conversations. They're talking about questions around interoperability, robustness, its scalability, resource optimization, and addressing ethical, practical, and cybersecurity risk. So these are some of the things that are going to be asked in that way. But my favorite thing is this, that what happens when you do not agree to what the bot or the AI has just suggested? As a clinician, what is the effect that, what do you do? Do you then go about in rubbishing it and say, we're not going to use you, or we are not going to take this particular, in that way. And one of the ways that we have been doing, particularly for an example that I'll give you in the next 2 minutes, is actually in the antibiotic selection. And we found out that at this point of time, we are just about 87% accurate. So we always ask the physician to use their own discretions in this. But as we move on, this is something which would go about in increasing, particularly when you are looking at hands-offs and conflicts between clinicians and AI. How we are using at this point of time is about, one of the areas where we found it to be maximum useful is to collate the data from the backend, the electronic data from backend, particularly for cancer patients who are returning with relapse or recurrence. And then we are looking at their summaries, imagings, labs, biopsies, pathology diagnosis, and then say, what are the possible ways of looking at it and what are the possible options that are available in that. So those are the areas where we are able to, do it in a much better way and get it in a much accurate way in that. Again, the question is, when a human being does all the kind of summation of this report versus when the LLMs do it, do the LLM miss out certain critical things which are necessary for the care decision? We're finding that out. Finally, also look at, what are the kind of healthcare professional skill gaps that we need to actually look at for training to effectively use AI tools, because in many cases we found out when we got the erroneous results, we found out that the input parameters were not appropriate at some point of time. And therefore, look at deployment bias. We might talk about what is deployment bias, where you selectively use it only in certain pockets where you know that it would succeed. Then you are putting it in such a way where you are seeing that it is, tailored to succeed in many ways. But if you are just also doing the opposite in that way, so how do you balance it and go about in deploying AI in your different solutions across the world? I'm now moving to the integration into the workflows perspective. And we have seen this particularly from the, how effective this is from the excellence in digital health perspective. So the kind of things that we require is that 5+1 pillars of digital excellence, where you are looking at operational backbone, shared insights, you're looking at a positive network effect in your, in your platform. We're looking at innovation versus alignment within your organization, and also seeing it from a perspective of whether you bring in third parties to actually, design and develop it for you in that. So example of this is in the work that we have been doing on tuberculosis detection, where we have now about close to 130,000 people screened, out of which our detection rate at this point of time is about 2%, which is better than the other detections mechanisms that I've seen. And this is something that we are running now as a government's pilot program in different places. But what it effectively does on the hospitals or other areas where we are working is to actually reduce 7 to 28% of the turnaround time. This is an example that I wanted to give you about what we are doing or in case of antibiotic selection. So whether it is an antibiotic selection in outpatient clinic, inpatient clinic, ICU, or wards or any other places, if you provide patient demographic data, comorbidities, current infections, you will be able to then go and to look into the older data and use a recommendation system and a machine learning on top of it to actually recommend you top 3 organisms and their corresponding antibiotics. We have used this in our system, of course, in a controlled private environment, and we have seen that the accuracy for the implementation is around 87% at this point of time, which means we do not have to either escalate or de-escalate medications, or antibiotics at this point of time. This is still research in motion. We presented these to one of the committees of WHO, and now they're very eager to see how we can go about in adopting it for other regions as well. Now, to lay that with what I talked about as the full blood count data on the research that we're doing on the University of Cambridge, it takes it into a completely different paradigm to say, if we are going to then use proactively at some point of time to, address sepsis and others. Finally, some work on throughput optimization to see, how does it happen in the hospitals to maintain or manage capacity constraints, disutility of resources, flow optimization to reduce overcrowding, organization-wise improvements for the clinical and operational outcome. So this is the scheme that we use for the opportunity and the scope organization-wide, use machine learning on top of it to identify capacity constraint and then look at continuous flow. But then the outcome and the operational measures are very similar to what we have kept it from a conventional point. My last slide, and literally my last slide, is actually to work on the aging AI models. Some models in healthcare AI are aging. They are more than 2 years, 3 years. And they face issues like data drift. The kind of data that they were building are now much more refined and curated, and therefore, they need to uplift themselves. There are also perceptions around the concept drift. Some of them are becoming obsolete because of the fact there is a new technology or a new model that comes in that way, or their overall accuracy has been declining over a period of time. How do you then go about in having those systems in your place to see what is the kind of oversight that you're building in for those older models? How do you bring in retraining, adaptive learning, ensemble models, robots testing, and explainability? So what was explainable in the previous way are now going to be completely different in unexplainable terms if you are, if your model has drifted or there is a data drift or concept drift in that way. So how is that oversight critical to maintain relevance in that perspective? Finally, no one, absolutely no one in the world can build AI models, particularly for clinical medicine, all by themselves. They require collaboration, they require building data consortiums, and that data consortiums comes from industry, that comes from hospitals and healthcare perspective, that comes from your cloud computing and the other partners, but also people who are working on responsible AI and all that. How do you bring all of them together to actually build effective data consortiums where you can build, design, develop healthcare solutions in a better way, and then go about in implementing it not only in your hospitals but worldwide? Thank you very much for patiently hearing.